Anyway, enough about the tiny details of the amino acids. We just want you to understand that they're not taking like a huge chunk of beef and just liquidizing it and putting it in a bag of TPN. Hello, welcome to Tala Talks NICU, where we take complicated medical concepts and make them super easy for you to understand. Today, we are talking about how to actually write for TPN. So really, before you watch this video, go back and watch the first video that we already filmed on kind of the general basics of TPN. We were initially planning on including how to write for TPN in just one big video. And then, as always happens, as soon as we started writing this out, it became abundantly clear that it was probably too much information for one video. So we're going to divide this part into two parts. In this video, we're going to cover the kind of macronutrients and the rates. So we'll go over how to write the rate or calculate the rate that the baby should be on of the TPN, and then we'll cover all the macronutrients. So we'll go over the glucose requirements, the amino acids, as well as the fats. In the next video, or kind of part 3 of the TPN series, we'll go over the micronutrients or kind of the electrolytes, as well as the vitamins and minerals and anything else that we might throw into a TPN bag. Before we continue, I would like to, as usual, ask you to like this video and to subscribe to the channel if you wish. And if you do send us comments, we love knowing where you are based, in what part of the world your NICU is in. It makes us really happy knowing that people are watching this from all over the world. Right, let's start with the first point, or the rate, which is really the first decision that you have to make when you are writing for TPN. And as we've already discussed in previous fluid and electrolyte videos, as you all know, when we consider really the rate, what we're really considering for every baby is the total volume of fluid that the baby should be getting over the course of 24 hours. However, in most programs, whether you write it by hand or whether it's an actual computer program, the program wants you to write the hourly rate of the TPN that you want to put the baby on. I'm going to give an example, however easy it is, just so that it sticks. So say you decide that you have a 1 kilo baby and you want to keep that baby on about 100 mLs per kilo per day. So because it's a 1 kilo baby, that baby needs to receive 100 times 1 or 100 mLs per day. So because there are 24 hours in a day, you do 100 divided by 24. So that baby should be receiving 4.2 mLs per hour, just under 4.2 mLs per hour. So that's normally the rate that you'd have to write in for the TPN. So what should the rate actually depend on? Like we've already talked about, the younger the baby and the smaller the baby, generally the higher the initial rate needs to be because that baby has increased insensible fluid losses. So increased fluid is being lost through their skin and sometimes through the lungs as well. So they need a higher initial fluid rate just to make sure they don't get too dehydrated. So, for example, if you're writing for TPN for a term 3.5 kilo baby with HIE, then you definitely don't want to fluid overload that baby. You're really worried about cerebral edema. So you might start that baby on 50 to 60 mLs per kilo per day. Whereas for a 500 gram 23 weeker, you probably want closer to 100 to 120 mLs per kilo per day. And if you have a 30 weeker, you probably want the fluid to be somewhere in between those two extremes. So maybe somewhere between 80 to 100 mLs per kilo per day. On that first day of life, you definitely don't expect a baby to get the full calories that you would eventually want to give that baby, kind of 100 and 120 calories per kilo per day. In fact, that first day of TPN normally only has about 30 to 40 calories per kilo per day because you're really not maxed out on the protein, on the fat, on the sugars, or even the volume. You have to slowly build up on all of those over the first few days of life. So really, no matter what volume initially the babies were started on, you're pretty much slowly going to build up the total fluid rate until you reach somewhere between 140 to 160 mLs per kilo per day. Sometimes the tiny micropreemies like the 23, 24, 22 weekers with really thin skin that are losing a lot of water, sometimes they might even need up to 200 mLs per kilo per day, but that kind of really is the exception. How you would advance the fluids over the following days after starting TPN would depend on two main factors. The first one is the weight of the baby as well as kind of the urine output. Like we've already talked about, we want babies to lose weight after they're born. In fact, we expect all babies to lose really up to even about 10% of their birth weight. If they don't lose weight, it means that they haven't fully transitioned yet. So they're still retaining their fluid. They're not diuresing adequately. This is normally a sign that the baby is pretty sick if they haven't lost weight in the first kind of 24 to 48 hours after birth. So we look at that. We look at how much the baby has peed as well as the baby's weight. If the baby is the same weight or has increased weight, then we definitely don't want to go up on the fluids because like we said, we expect the baby to lose weight within the first few days of life. So for example, your term baby with HIE on 60 mLs per kilo, if they've gained weight, you might even drop that fluid down to 50 mLs per kilo per day in that first kind of 24 to 48 hours. When you finally see that the baby is actually losing weight, at that point, you can start going up on the fluid volume. So, for example, you started a 32-week on 8 mLs per kilo per day, and the next day you see that they're down 2% from their body weight. At that point, you could advance their fluids by, normally we go up by about 20 mLs per kilo per day. And you go up every day as long as they're losing weight until you reach 140 to 160 mLs per kilo per day. If, for example, kind of same situation, you have the 32-weeker and at 24 hours of life, you notice that the baby's actually down 9% from their birth weight, then at that point, they might need to go up by more than 20 mLs per kilo per day. They might need to go up by 30 or 40 mLs per kilo per day, just to make sure that their total weight loss doesn't go far beyond the 10% below birth weight. The second thing that you need to look at when you're determining how to advance the rate is the electrolytes. So generally when we're starting babies on TPN, we follow the electrolytes pretty closely because we can't really predict exactly what each baby was going to do. Go back and watch the first video on more reasons for why that is. So let's say, for example, that you started a baby on TPN and then 24 hours later you get the electrolytes and you see that the sodium level is 149, obviously pretty elevated. At that point, we would be concerned that the baby is a bit dry or a little bit dehydrated, obviously, especially if the baby is 11% below birth weight or whatever. But it's just kind of one more thing to think, okay, maybe we're not giving enough fluids. So in the first 24 hours of life, we don't normally give a lot of sodium. So you can't really look at it and be like, oh, we just gave too much sodium. Most likely we just didn't give enough fluid. So if a baby has a sodium level of 149, then you probably want to go up by more than 20 mLs per kilo per day on the TPN rate. The opposite of that is if you get the sodium level at 24 hours of life and the sodium is 130, and at that point, you'd think, okay, maybe baby hasn't started diuresing yet. So we probably don't want to go up on the fluid level because we already are pretty diluted. The fact that the sodium is 130. We know eventually that the baby is going to pee out that excess fluid and the sodium is going to climb up. So we normally play with the sodium level in the first few days of life by the amount of water that we give, not by going up and down on the amount of sodium that we give. So in summary, the overall guideline is the smaller the baby, the higher the initial fluid rate, and then you pretty much advance by 20 ml per kilo per day until you reach somewhere between 140 and 160 mLs per kilo per day. Obviously, if you're going up on feeds and stuff, then that's kind of the total fluid volume. But essentially, how fast you go up and whether you go up at all is going to depend on the baby's weight, the baby's urine output, and the baby's electrolytes. Number 2, now let's talk about the macronutrients part of the TPN. And when we say macronutrients, we mean sugar, fat, and protein. So number 2 is us going over how to write for the carbohydrate component of TPN. So the carbohydrate component of TPN is given as dextrose monohydrate. By the way, as an aside, in the NICU, we use the terms dextrose and glucose pretty much interchangeably because they pretty much mean the same thing. Glucose comes in 2 different isomers, L-glucose and D-glucose, which are basically mirror images of each other. D-glucose is the same as dextrose and it's found a lot more commonly in nature. So D-glucose and dextrose are exactly the same thing. Okay, so a few things you need to know about the dextrose component. 1 gram of dextrose has 3.4 calories per gram. So altogether, it does contribute a lot to the calories that an infant is receiving. In fact, The carbohydrate proportion is the highest contributor of the calories to the baby's TPN. It contributes somewhere between 50 to 80% of the baby's calories in the TPN. You also need to understand that the amount of glucose we give is really the only place in the TPN and the amount of energy that we're giving that we have a little bit of freedom with. So for example, with the proteins, we're capped out at giving between 3 and 4 grams per kilo per day. With the intralipids, we're capped out at giving 3 grams per kilo per day. So we're maxed out on the amount of calories we can give from proteins and fats. Whereas if a baby is not gaining weight, then you can carry on going up on how much glucose that you're giving that baby, as long as the blood sugar and everything isn't out of control, until we get that baby growing. So really, glucose is the only macronutrient where we have a little bit of play with it. The other important differentiation with glucose is that it is the only macronutrient that's written as a concentration. So for example, say you have a baby that is getting 100 mLs per kilo per day of D10, TPN, and is getting 3 grams per kilo per day of protein and 3 grams per kilo per day of intralipids. If the next day you go up to 120 mLs per kilo per day, then the baby will still be getting 3 grams per kilo per day of the amino acids, 3 grams per kilo per day of the intralipids, but will be getting more sugar because the concentration has stayed the same, but the volume that you're giving is now larger. So that baby's GIR, or the amount of sugar that the baby is getting, has actually gone up, as has the calories. So that's why it's really important when you're writing for TPN that you are actually considering the GIR, or the glucose infusion rate, because that is not dependent on the volume, the daily volume that you're giving, or on the actual concentration of sugar that you're giving. Remember, when we write like D10, that means 10 grams of sugar in 100 mLs. Obviously, if the baby's getting 300 mLs in a day or 100 mLs in a day, the amount of sugar that they're getting is going to be very different. Whereas the GIR eliminates that, and it's the calculation of how much sugar the baby is getting per kilo weight per minute. Go back and look at the GIR video that we filmed a few months ago, just to remind yourself what all those conversions are. So on the first day of TPN, where do you start with the GIR? And generally what we always say is that you want a GIR somewhere between 4 to 6 milligrams per kilo per minute to start with. A term baby who is on 60 mLs per kilo per day on D10W will get a GIR of 4.2 mg per kilo per minute on that combination of fluids. For a 24-week infant receiving 120 mLs per kilo per day, then to get that same GIR, the dextrose only has to have a concentration of D5, or 5 grams in 100 mLs. So practically, in term babies, we generally start on a dextrose of D10 or D12, because roughly with the fluid rates that we normally start at, that does give a GIR somewhere between 4 and 6. Like I keep saying, the smaller the baby, the higher the fluid rate needed, so that same GIR can be achieved with much lower sugar concentrations. So for the micro preemies, we'll often start them on D7.5, and this might even have to be dropped down to D5 just because the baby may have hyperglycemia. As an aside, another aside, nobody can really decide at what point we should be actually treating the hyperglycemia. Obviously, if the baby is symptomatic from it, and generally you're symptomatic with hyperglycemia by getting that osmotic diuresis, so babies just start peeing out loads and loads and loads, like above 5 mLs per kilo per hour, then that is concerning. But generally, the definition of hyperglycemia is a sugar above 150. But even though that is hyperglycemia, generally people won't kind of start acting on it until the blood sugar level is above 180. At that point, you should probably be making some effort to lower the GIR. If the blood sugar level is above about 250 and it's repeatedly above 250, even though you've kept lowering the GIR, then at that point you might consider actually starting insulin on these babies. Standard practice is that we generally don't take these babies below a GIR of 4, just because we want to make sure that the brain is getting the sugar that it's needed, as well as we want to try to give these babies good calories for some level of growth and for their general energy needs. And so generally, we don't want to go down below a GIR of 4. Insulin can be given as a intermittent dose, or it can be given as a drip, depending on how out of control your blood sugars are. And we'll take them all the way up to about 0.1 units per kilo. This is another discussion. If you want to hear more about hyperglycemia, then please leave a comment below. So to make sure that a baby doesn't have hyperglycemia or hypoglycemia, which is sugars less than 45 to 60, depending on how old the baby is, then we should always be checking sugars when babies are on TPN, even if you're not getting routine lab work. So after you switch out the TPN, you should be getting a sugar kind of an hour or so after the baby's on the new TPN, as well as at some point about 12 hours later, just to make sure that the baby's sugars are within range. So after you start on the GIR of 4 to 6 mg per kilo per minute, then you want to slowly advance the GIR every day by about 1 to 3 mg per kilo per minute until the baby receives about 12 mg per kg per minute. 2 points here. Obviously, you're only going to advance the GIR if the sugars are under the parameters that you want them to be. So you definitely don't want them too low, but you definitely don't want them too high. So generally, if the sugars are above 150, you're probably not going to be advancing the GIR. The second point is that because the GIR calculates the mg per kg per minute, if the dextrose concentration stays the same, so you stay at D10, but you're advancing the volume every day, then by definition, that baby is going to be getting an increasing GIR. So you don't necessarily have to be going up on the dextrose concentration. So make sure that every single day you're looking at the GIR of the baby, not just the dextrose concentration that you're giving. Like we've already said multiple times, some babies need more calories than other babies. So big babies that are healing from surgeries obviously are going to need more calories to heal. Or if a preemie baby is breathing really rapidly, then they're going to need more calories because they're burning it in their lungs. And like we've already said, the way that we give higher calories is by going up on the GIR, or by the amount of sugar that we're giving the babies. Ultimately, if a baby is on pure TPN, we want to give them about 100 calories per kilo per day. Remember that if a preemie baby is actually eating, they need more calories per kilo per day, somewhere close to 120 calories per kilo per day, because just logically, they're going to need a lot more calories in the process of actually eating and digesting and absorbing the food, rather than the nutrition being put directly into their bloodstreams. I just want to make a note here of how crazy the nutritional requirements are for a growing premature infant that actually needs 120 calories per kilo per day. I mean, if you're a 60 kilo woman, which is about 132 pounds, then 60 times 120 calories per kilo per day is 7,200 calories per day that you would need. So that's 7,200 calories of just basically basal metabolic rate. You're just lying there, no walking around the unit, no sport, no exercise. That's what you need just to kind of exist and to get a little bit longer. I really wish I had that metabolic rate. Number 3, let's talk about the second macronutrients, which are proteins, which, as we know, are so crucially important for the growth and development of premature babies. More and more data is emerging about the importance of starting protein really early, like within a few hours after birth, for these preterm babies. It has immediate benefits, putting them into like a positive nitrogen balance, getting them up to their birth weight much sooner. And it also has much longer term benefits, so improving their weights at discharge. So by starting protein earlier, within a few hours instead of at like day 2, the babies have better weights at discharge, and it's been shown to improve even their neurodevelopmental outcomes at like 18 months. The protein component of TPN is administered as a solution of amino acids. Remember that amino acids are the building blocks of the proteins. And there are lots of different amino acids, and there are different solutions for different concentrations of those amino acids. Compared to adult bags of TPN, the amino acid solutions for infants have a lot more of what we call the essential amino acids for the babies. Remember from your basic science lectures that amino acids for the growing baby are divided into essential or non-dispensable and non-essential or dispensable amino acids. Indispensable or essential amino acids are the amino acids that cannot be produced by the body, and so you have to get them externally, exogenously, normally within your diet. Dispensable or non-essential amino acids, on the other hand, can be created by the baby, so they don't necessarily have to be given to the baby. In infants, the classic essential amino acids are the ones used most structurally. So for example, the branch chain amino acids. So for example, isoleucine, leucine, and valine. But to kind of complicate matters with the TPN, there are other amino acids that aren't that necessary structurally, but have really important roles. For example, cysteine and glycine are major components of the antioxidant glutathione. And the amino acid arginine is crucial in nitric oxide synthesis, so NO, as well as creatine synthesis. Cysteine, arginine, and glycine are normally considered conditionally essential, which means that you can make it unless there is some sort of stress on the body, which, if you think about it, for most premature babies, they are undergoing some level of stress. I mean, just by being born early. So more and more people are beginning to argue that these conditionally essential amino acids in preemie babies are actually probably pretty essential. Anyway, enough about the tiny details of the amino acids. We just want you to understand that they're not taking like a huge chunk of beef and just liquidizing it and putting it in a bag of TPN. The concentration and the amount of amino acids is very carefully measured, and basically it depends on the amount of amino acids that's found in breast milk, as well as from a whole bunch of basic science research that's been done. As always though, we know that there is always room for improvement. So a few more basics about the protein. A gram of protein provides 4 calories per gram, so a little bit more than the glucose is 3.4. And all in all, the proteins provide about 10% of the calories in a bag of TPN for the babies. And like we keep saying, there is a lot of data supporting the early administration of good doses of amino acids or good doses of protein. In the past, we were always nervous about starting too much protein too soon, and we'd normally start at like 1 gram per kilo per day and then advance really slowly. Now we know that babies tolerate higher doses and a faster advance than that, and generally do a lot better with it. So generally, you would start on the first day of TPN on either 2 to 3 grams per kilo per day of the amino acids in the TPN, whether it's starter TPN or the actual bag of TPN that you're writing for, and then advance each day by between 0.5 to 1 gram per kilo per day until you reach the maximum amount of protein that you can give. So for a term baby, that's somewhere between 3 and 3.5 grams per kilo per day, and for a preemie baby, that's somewhere between 3.5 and 4 grams per kilo per day. One last note about the amino acids. There's always kind of going back and forth about whether we should be following the BUN levels and whether we should slow down the advancement of the amino acids with elevated BUN levels. A recent Cochrane review showed that, unsurprisingly, the higher the amino acid levels being given, then generally the higher the BUN levels, which is blood urea nitrogen. But no studies have kind of definitively shown that even with a higher BUN levels, the babies aren't getting more advantage or benefit by giving those higher amino acids than by actually worrying about the BUN. A recent Australian consensus suggested accepting BUN levels of 14.3 millimoles per litre, which is the same as 40 mg per deciliter of the BUN. They did, however, say that we should only accept slightly elevated BUN levels as long as the ammonia level is normal. And they considered a normal ammonia level as anything below 122. Honestly though, practically, in the units, because we know that the amino acids are such a huge advantage to the babies, then we'll really allow those BUNs to creep even higher than that, maybe into the 60s and the 70s, and as long as kind of nothing else is going on that's crazy, just because we know that there's going to be such a huge advantage from the babies getting the protein that it needs. Now, number 4, let's talk about the last macronutrient that we haven't discussed, and that is fat, or the lipid emulsions. Obviously, fats are an essential component of the TPN because they provide the essential fatty acids, so fatty acids that the babies can't make themselves, and they are such a concentrated source of energy that they really allow babies to grow better. As you would expect, 1 gram of fat provides a lot more calories than a gram of protein or dextrose. In fact, a gram of fat gives between 9 to 10 calories per gram. Generally, in a bag of TPN, the lipids provide between 30 to 40% of the total calories. Again, note that even though they have higher calories per gram, the carbohydrates are the largest source of calories in the TPN. And for everybody doing their neo boards, the essential fatty acids are linoleic acid and alpha-linolenic acid. And just so that you also understand this, it doesn't take a lot of fat to make sure that a baby does not get an essential fatty acid deficiency. So somewhere between 0.2 and 0.5 grams per kilo per day is enough every day to prevent a essential fatty acid deficiency. So for example, if you give a baby maybe 0.5 or 0.6 grams per kilo per day 3 times a week, then that should be enough to give those 2 essential fatty acids. There is also a lot more research being done recently on PUFAs, or very long chain polyunsaturated fatty acids, which are kind of conditionally essential. So we've basically extrapolated from adults, and adults that are capable of making these fatty acids, and so kind of initially considered them to be fatty acids that could be made by infants. But just like with the amino acids, effectively, the infants are kind of under constant stress. So most likely they're not making enough PUFAs themselves. The PUFAs we speak about the most are DHA, which is docosahexaenoic acid, and EPA, which is icosapentaenoic acid. These PUFAs are thought to be really critical in the brain and eye development of growing preemies. And actually, based on all this research, a lot of these PUFAs are actually being added to even infant formulas and even term formulas, hoping that it would somehow help brain and eye development. It's really difficult to prove that they actually make a difference, and no study has definitively shown this for the actual formulas. So if you're not giving a baby the fatty acid component of the TPN, and they're not eating at all, so they're not receiving any of the essential fatty acids, not only will that baby obviously grow really slowly because you're just not giving them a whole bunch of calories, but they could also end up with an essential fatty acid deficiency. And what that can result with is elevated LFTs, so high AST and ALT. They can end up with bad thrombocytopenia and then a really, really bad rash over their bodies. So if a baby on TPN develops a really bad rash, the first thing you need to be thinking is, what nutritional component am I missing? Is it lipids, or is it, for example, zinc? There's a few different lipid formulations that we use, and we talked about this more in the first part of the TPN video as well as in the short bowel syndrome video. But generally, the ones that we use most commonly in the US are intralipids, which is basically a soybean-based lipid, as well as SMOF, which stands for soybean, MCT oil, olive oil, and fish oil. As an aside, since this whole video is about little asides, soybean oil does not contain any PUFAs, so the DHA and the EPA, whereas the fish oil is absolutely full of them. Also, fish oil is thought to be very anti-inflammatory. The fish oil also has been shown to have antioxidative effects, which potentially may decrease the incidence of BPD and ROP in growing babies. We do know that the fish oil is less hepatotoxic than the soybean oil. So numerous studies have shown that you are less likely to end up with cholestasis if a baby is on fish oil versus the soybean oil. But basically, all the different formulations of fats used around the world, Europe and Australia and Asia and everywhere, are basically different percentages and formulations of this same group of fats. As we talked about in the first video, the fats are hung in a separate bag from the TPN, but we also generally run the fats over a total of 24 hours. The other thing that you need to know is, for both intralipids as well as SMOFs, the concentration of the fatty acid versus the fluid in the bag of the fat is 1:5, or 20% of the bag of fluid is actually the fats. There isn't a great consensus on what dose we should be starting lipids at in the unit, or really even how quickly we should advance them, but it is completely agreed upon that the maximum fat concentration or the maximum lipids that we should be giving a baby is 3 grams per kilo per day. Generally, most units start at 1 gram or 2 grams per kilo per day and just advance by normally 1 gram per kilo per day until they reach 3 grams per kilo per day. So let's give an example. Say you have a 2 kilogram baby and you want to start at 1 gram per kilo per day of lipids. So that's 2 kilograms times 1, which is 1 gram per kilo per day. So you want to give a total of 2 grams a day of the lipids. So you do 2 times 5 because the concentration of the bag is 5 to 1. So you want to give a total of 10 mLs of lipids in 24 hours. So 10 divided by 24 is 0.42 mLs. So you run it at 0.42 mLs an hour to give this baby 1 gram per kilo per day. Some units round up to 0.4, some give the to 2 decimal places. Also, some computer programs, just like with everything else, will ask you for the total amount of lipids and it will do the calculation naturally. Other computer programs or other kind of just sheets want you to actually calculate the rate. So just get used to it all the time. If you also get used to the general rates, as well as the amount of lipids that a baby's given, then you're much less likely to make an error. There are a couple of concerns when we give the lipids. The other eternal question, just like the BUN with the AA, is whether we should be checking the triglyceride levels and when babies are on TPN, and if we are, then what do we accept? Over 30 years ago, Dr. Adamkin suggested that we can accept triglyceride levels up to about 250 milligrams per deciliter. More recent studies have suggested that having triglycerides much higher than this may actually increase mortality as well as increase ROP. So most likely you should be checking triglycerides occasionally, especially in the very tiny babies that have a much higher chance of not tolerating the lipids at all and suddenly getting a triglyceride level of like 1,000 or something. The other thing that we worry about with lipids, and this is something that we talked about in the bilirubin video, so you can go back and look at that first video on jaundice, is that the lipids actually bind to albumin. Now, if you remember, when you are a little bit worried about the unconjugated or the indirect bilirubin, that is actually what binds to albumin. And if that bilirubin is not bound to the albumin, then it is free indirect bilirubin and it can cross into the blood-brain barrier and cause kernicterus. So if you have high lipids and they are binding to the albumin, then logically you're going to have more free indirect bilirubin that could go into the blood-brain barrier. So if you do have a sick baby, especially a preemie baby with really high indirect bilirubin, you probably don't want to increase the lipids rapidly because you want to keep those albumin just as free as possible to bind the bilirubin. The other things that we used to worry about, especially with the previous formulations of the lipids, like especially the soybean oil-based lipids, was that we were worried really because of their kind of pro-inflammatory component that they could worsen respiratory diseases. So they could worsen PPHN, so persistent pulmonary hypertension, as well as increase the risk of developing BPD or just worsen BPD. We don't worry about this as much with the newer formulations that don't seem to be as pro-inflammatory. Well, that's it. I hope it wasn't too much information. It's really hard to discuss really any topic in neonatology without just wanting to go down a rabbit hole and give all the information that I think even might be slightly relevant. So I hope it wasn't too much. I hope it wasn't too little. If it was, then let us know what else you'd like to hear about. Again, thank you so much for being here.